Hello there.
Hi,
Steve,
how are you?
Steve, would you mind turning that off just for a little bit while we get this going? Good. I can introduce you once we start, and then I'm at a conference, so I apologize if it's loud. I'll mute myself and probably turn my video off just so it's not distracting, but you got everything up, I see, right?
I do.
Okay, awesome. Okay, so I will let this be on so people can come in as they choose. And then at noon, I will introduce you, Dr. Bird. Does that work?
Sounds great.
Okay, thank you so much.
My pleasure.
I don't know if I'll be on at the end of the session because we are at this conference. So if you want to take questions, or I can put my email in the chat if people want follow-up or whatever, we can get them whatever they would need after this is over as well.
I'll try to stop a couple times and ask questions and leave some time at the end for questions.
Wonderful, thank you.
Sure. So what would you say has been the highest number of students that have been placed out of state?
69.
Jen, I was right. Let me try.
Hello, everybody. Welcome to the first webinar series with Dr. Bird about fetal alcohol syndrome. We will be doing a several part series on this topic for different backgrounds and disciplines for education purposes, connection and things like that. So today is our first one, just prevalence rates, things like that. So I welcome Dr. Bird here. Throughout the webinar, we will stop to allow for questions, or if you want to utilize the chat box, that's also welcome. And at the end, we will have questions, as well as this will be recorded and we will share it after as well. So with that, go ahead, Dr. Bird, and thank you so much for doing this for us.
My thanks for this opportunity. So today, I wanted to spend some time talking with you about fetal alcohol spectrum disorder, which is essentially what we used to call fetal alcohol syndrome and fetal alcohol effect. It's important to understand that when a woman who is pregnant drinks, alcohol goes from her stomach into her bloodstream, circulates in the bloodstream, as this picture shows, goes across the placenta into the fetus, so that the mother and the unborn baby have the same blood alcohol concentrations. So every time the mom drinks, the fetus is exposed to alcohol. As long as the mom has alcohol in her bloodstream, the fetus has alcohol in their bloodstream. Now, one of the things that I think might be kind of surprising to people is how much alcohol does it take to put you in a category of what we call risky drinking. And in that category, you're drinking enough that your unborn baby, the fetus, is at risk to have a fetal alcohol spectrum disorder. So this means that at some point during pregnancy, you drank 6 drinks in a week, and you did that twice. Or that at one time you had 3 drinks and you did that twice. So the amount of alcohol to place you in a category of risky drinking is quite low. And I've been working on this problem for around 40 years now. And what we find is that as we refine our studies, we demonstrate that alcohol is a very potent teratogen, and that even in low levels, it's able to cause problems. So this is a child with the facial features of fetal alcohol syndrome. Now, I want to start at the beginning and emphasize that when people are diagnosed with fetal alcohol spectrum disorder, only about 1 in 7 or 1 in 10 of them will have facial features. So this is a child, the typical person with FASD would be small, have a small head circumference, a thin upper lip, an upturned nose. That little area between the nose and the top lip is smooth. It doesn't have those 2 little ridges. Sometimes they have slight abnormalities of the ear, and most of them have a small eye. Now, because this is relatively uncommon, this particular picture of facial features, we don't typically assess these unless there's some need to. Most of the time, we're more interested in figuring out if you have a diagnosis of fetal alcohol spectrum disorder. I have one more slide on these facial features. So these range from 1 through 5, and you can see that categories 4 and category 5 are considered abnormal. Category 3 gives us something to argue about at meetings, and category 1 and 2 are just normal variations. So in most children with fetal alcohol syndrome, which again is a very small number, they have a thin upper lip. The lip is not curved. It's fairly straight. An upturned nose. Those two little ridges that normally occur under your nose are absent or very indistinct. This is going to really be the last that we talk about facial features. I'd like to emphasize that during pregnancy, when a woman drinks, alcohol enters her bloodstream, enters the fetus. One of the main effects of drinking during pregnancy is that alcohol results in changes, damage to the brain. So every episode of drinking during pregnancy is an episode of brain damage. And you can see these two brains here. The top one was exposed to alcohol and the bottom one was not. All of the dark shading in the top brain are cells that are dying from a single exposure to alcohol. Now, because this is a time during pregnancy, the brain is still making enormous numbers of brain cells. But this gives you some idea of the teratogenic or birth defect causing potential of alcohol. These changes to the brain typically result in impairments. And these impairments are usually found as vision impairments, difficulties with attention and memory and learning, problems with sleep and eating and toilet training, problems with judgment, impulsivity, thinking before you act, evaluating the consequences of your actions. One of the reasons that we're very interested in early identification is that when we look at this exit sign here, we can see risk factors which are coming up. And it seems clear that if we have early identification, we have a good deal of opportunity to prevent many of these problems, including abuse, neglect, development of some types of mental health problems associated with abuse, neglect, multiple foster home placements. We have a lot of school problems, many of which could be minimized. I would say at least 2/3 of all the legal problems in this population could be minimized with early identification and appropriate management. A lot of difficulties with substance abuse. And of course, as I think perhaps all the parents, foster parents, families who have children with FASD realize, not that many of these people are going to live independently. Many of them are going to require some help. We've done 4 prevalent studies in the state of North Dakota. The first one was a long period, a 23-year-long study where we tried to identify FASD among live births. The rate was 1.1%, 1 out of 100. And again, this was mostly people with fetal alcohol syndrome because this was before the spectrum was broader. Second, we screened children going into kindergarten, as you can see, for quite a number of years. 1 out of every 17 children going into kindergarten had an FASD, was identified as having an FASD. Second one, for 13 years, we screened kindergarten students and found about 1 to 2% of them had an FASD. We looked at early periodic screening diagnostic testing, all children who entered that program in 1 year, and we found that 1% of them had an FASD. So when we look at this second site, prenatal care child tracking, the finding that 6% of those children had FASD was quite alarming. We later worked with people from that community and made some remarkable changes there. Where are we at in North Dakota today? Well, if you follow this, you'll recall that there were 4 prevalent studies published in the last year, screening children in the 1st grade across the United States. They found that 5% of school-age children in the 1st grade had an FASD. So in North Dakota, that would mean that every year we have 515 new cases. Turns out that's 43 a month, or 10 a week, or 1 new case every 17 hours. Sadly, 105 of these children will have an affected sibling. In the state of North Dakota, we have 9,270 children, birth through 18, who will have an FASD. And depending on how you categorize this, we think there's about 1,240 diagnosed. So somewhere around 8,000 who are undiagnosed. And you can imagine the number of adults and elderly people with FASD that we have in North Dakota who are undiagnosed. I'm going to stop here and see if there are any questions before I go on to some of the systems issues around FASD. So I wanted to spend a little bit of time thinking about how FASD might impact the state of North Dakota. And we have published a very substantial number of cost studies of FASD, both in North Dakota, the United States, global cost estimates, a huge number of cost estimates in Canada and South Africa, and getting ready to publish some cost estimates for Ireland and the Congo, where we have sites. So in general, the annual cost of providing services to children with FASD is about $22,810 a year. Now, this is excess costs, or these are costs above what we pay for typically developing children who do not have FASD. In a study which was absolutely amazing, in a study which was absolutely amazing to us, we sent cost diaries out to people taking care of children with FASD. And we found that they spend $25,900 a year out of their own pocket. So this is things related to holes in the wall, replacing furniture, screen doors, driving people places, paying for unreimbursed medications, having to work part-time because you can't work full-time, avoiding a promotion, being unable to work at all, paying money for respite care, babysitters, etc. So actually, the majority of the burden is being shouldered by the families. And this was very helpful for us in understanding why so many of these families have so much financial difficulty. So you can be a middle-class typical family, take on the care of a couple of children with FASD, and very shortly, you're going to have financial problems. The cost of corrections, this is brand new data, turns out to be about $4,880 a year. So the annual cost of a child with FASD in North Dakota, $53,683. For adults, some of these costs vary, but for adults, it's $49,000 a year. Now, big table here, we're not going to, by any measure, go through all of this, but I just want to focus on a couple things. This is from a very large study we have just completed. We're getting ready to submit for publication. It involves several million people from the United States. So if you look in this column, we'll just pick one, birth through age 5, and you look straight down, you can see that if you have Medicaid coverage, if you have FASD, Medicaid spends $12,397 a year. The typical child with Medicaid coverage who does not have FASD is $2,496. Outpatient care, $16,600 for FASD, $1,300 for children who don't have FASD. Inpatient care, $63,900 versus $12,000, and you can go on down. When you look at the cost differences between Medicaid and private insurance, you can see the dramatic impact this is having private insurers. In North Dakota, Blue Cross Blue Shield, Sanford, other substantial payers, a child with FASD is costing about $16,000 compared to $2,200 for a child the same age. Outpatient care, about $40,000. Inpatient care around $139,000. And so you can understand where a significant part of these healthcare costs come from. There are huge differences in the demand on healthcare providers for children with FASD compared to children of the same age and essentially paid for by the same type of insurance who don't have FASD. So the cost per day in North Dakota for fetal alcohol spectrum disorder is about $150,000, about $54,872,000 a year. The cost to prevent a case of FASD ranges depending on how you do it. But if you try to prevent FASD among women who've already had a child with FASD, we can do that for somewhere around $32,000 per case. So for $54 million a year, we can afford and should be investing huge amounts of money in prevention. When we think about costs for FASD for children, we could say, well, by the time they reach age 18, we will have spent about $966,000 on them. By the time they reach 50, $2.5 million. A number we use often in cost studies. How many years does it take you to reach $1 million in FASD? It takes 18.6 years to spend $1 million on cost of care. How does this compare to other conditions? Fetal alcohol spectrum disorder, 329 times more costly than just children with ADHD. Now, a lot of kids with FASD, a lot of people with FASD also have attention deficit hyperactivity disorder. FASD is 318% more expensive than autism, 20 times more expensive than asthma, 270%, not times, 270% more expensive than diabetes, and 538% more expensive than epilepsy. So one of the things that is emerging, I think, worldwide is that having spent 40 years largely neglecting FASD has produced a massive number of affected people who need very high rates of services, which are very expensive. And we're spending lots of money on them. One of the issues that often comes up with FASD is that people say, I don't see the point in screening for this. I don't see what the value of a diagnosis is, because we're already doing everything that we would do anyway if they were identified with FASD. So I'm going to try to convince you that nothing could be further from the truth. Prenatal alcohol exposure drinking during pregnancy is associated with a 4 to 10-fold increase in stillbirth, a 10-fold increase in sudden infant death syndrome, a 13-fold increase in death from infectious illness. Now, I want to take a moment here and recognize there are many causes of stillbirth, many causes of sudden infant death syndrome, many causes of infectious illness. And so drinking is not the only cause for these. People with fetal alcohol spectrum disorder have a 5-fold increased risk of premature death. In fact, in the studies we did in North Dakota, the overwhelming majority of the deaths in the children occurred quite early in life. When you have a family of children with FASD, or if you have a family where one child is diagnosed with FASD, any sibling in that family also has a 5-fold risk of premature mortality, whether or not they're diagnosed with FASD. Now, I want to just dwell on this for a minute, because one of the most amazing findings that has received shockingly little attention is that if a woman has a child diagnosed with FASD, the risk of her dying prematurely increases by 33 to 44 times. If she lives in North Dakota, she has a 44-fold increased risk in dying about 30 years younger than she otherwise would have. Something like 50–60% of these deaths will occur before the woman reaches 50. So as people are beginning to look at the huge increases in risk of women dying and women who've had children dying, almost none of these studies include fetal alcohol spectrum disorder. Kids with FASD, a 15% increased risk of a head, or 15% of them have a head injury. The overwhelming majority of these from abuse. If you have a child with FASD, they're 19 times more likely to enter juvenile corrections. They're 25 times more likely to enter foster care. They're 25 times more likely to enter residential care facility. 15% of them will live independently. 85% won't. So it seems clear that if we had early screening, early identification we could prevent much of this. The fact that we don't seems to me to be an unfortunate series of choices. Just like the amount of alcohol that it takes to put you in a category of risky drinking is surprising to most people, I think this will also surprise a lot of people. In the United States and absolutely in North Dakota, fetal alcohol spectrum disorder is the leading identifiable cause of intellectual disability. It's the leading identifiable cause of mental disorders in children. It's the leading identifiable cause of attention deficit hyperactivity disorder. It's the leading cause of placement in residential care, juvenile corrections for people who have developmental disabilities, and is by quite a margin the leading cause of learning disabilities. So over the next years, as people become more and more aware of this, become more and more attuned to the dramatic impact drinking during pregnancy has, and we see systems changes to improve our identification of these kids, much like we've had over the past 15, 20 years with autism. The same thing's going to happen with fetal alcohol spectrum disorder, because it's much more prevalent, it's much more expensive, and for children on the severe end, there are many, many more kids with FASD on the severe end than there are with autism. Come as no surprise, I think, it's not the leading cause, but a leading cause of placement in foster care, mortality, outpatient mental health demands, very, very significant cause of psychiatric hospitalization, big role in special education placement. Alcohol is especially important as a teratogen on the vision system. So fetal alcohol spectrum disorder is a big cause of visual impairment and impaired adaptive behavior, which is a measure of people's ability essentially to live independently. Before I go on, I'm wondering if anybody has any questions they might like to ask. So for parents, foster parents, adoptive parents, this graph will come as no surprise. The severity of FASD tends to increase across the lifespan. This is because as you get older, we expect more, we demand more from you. And when you have damage to your brain and you cannot meet those demands, we have increasing problems. As you grow older, the number of mental health problems you're diagnosed with increases, especially in this population, especially in people with FASD, because it's just a very common cause of lots of mental health and developmental disorders. So for people who have a child with FASD, one of the things very difficult to convey to people is that doing well early does not protect you from risk later in life. And for that reason, we encourage people to keep coming back for follow-up so we can follow along with them and their family and try to get a jump on these problems before they escalate, especially school failure, mental health problems, difficulties with the correction systems, to avoid changes in foster home placements and to avoid residential care. That's essentially a significant amount of what we're trying to do by these follow-up visits. I'm going to spend a little bit of time on the issue of FASD and corrections in general. So forgive me while I jump ahead one slide here. So in Canada, a study was done 9 or 10 years ago, demonstrating that people with FASD in that state or in that country were 19 times more likely to end up in juvenile corrections. It seemed for a long time that that was probably just a Canadian fact. But now we've come to realize that this is especially true in the United States. So 2 studies have taken place. One of them, a very large study in Minnesota, showed that by screening children in juvenile corrections facilities, identifying them with FASD, they made what I think you'd have to call dramatic changes in the outcome for those children. When compared with kids who weren't screened, diagnosed, and had changes in management, kids with FASD just did dramatically better. So when you think of the impairments that children with FASD have, among those are multiple problems with the way your brain works, the way you understand, the way you attend, the way you remember, the way you recall, the way you answer questions. So when children enter a juvenile facility, they are extremely susceptible in those settings. So this is a pretty useful study. Other people have essentially found similar findings. In this study, 43% of the juveniles who were in a corrections setting had given at least one false confession. 2/3 of them had been charged with an additional crime based on that confession. So the main problem occurs during any kind of interrogation, actually also occurs frequently in court, where children with FASD incorporate information they have heard into the story that they're telling. Some people consider this avoidance, manipulation, deception, but in fact, it's a widely known, well understood symptom of confabulation, where when they're missing information and they hear something similar, they pick up that information and include it in their story. It's a very serious problem when children or people with FASD are being interrogated. The Supreme Court in Florida had an opinion on this link between fetal alcohol spectrum disorder and corrections. And they opined that consequencing somebody for damage to their brain that they can't control, didn't cause, and can't prevent is inappropriate. And I think they stated this quite succinctly. We can envision few things more certainly beyond one's control than the drinking habits of a parent prior to one's birth. Big slide, we're not going to go over all this, but what's some of the advantages of early identification of alcohol exposure? Now, before I answer that, let me just back up for a second. So for the past 10 years, worldwide, we have seen steady increases in the number of people who drink alcohol. Steady increases in the amount of alcohol that people drink. Steady increases in the number of women who drink. Steady increases in the number of women of childbearing age who drink, and steady increases in the number of pregnant women who drink. Beginning before the pandemic, accelerating enormously during the pandemic, was the amount that individual people drink. So I think we can anticipate that fairly large numbers of children had exposure to more alcohol during the pandemic than they would normally be exposed to. More pregnancies were exposed to alcohol than we would normally expect. Now, this has been a trend going on for a long time. More alcohol, more people drinking, and the people that drink more. But this certainly accelerated pretty dramatically during the pandemic. I think is still going on. So, drinking during pregnancy is associated with a late start for prenatal care, less prenatal care. Identification of a woman who's drinking during pregnancy could decrease risk for future pregnancies to be exposed. Identifying this allows us to hone in on a mother and all the children born to her as people who have high health needs and a lot of specialty health needs. Drinking during pregnancy is associated with a lot of exposure to adverse childhood experiences or ACEs. Substance use is the primary cause of children being placed in foster care. 85% of children with FASD have been in foster care. What would be the benefit to the mother? Well, we'd identify a woman who has a very substantial increase in risk to die. By helping her, we decrease risk of her drinking in future pregnancies. Both the mom and the children may have an FASD. Some of you may have heard of the Don't Quit the Quit program, which is the College of Nursing here at UND has a pretty substantial grant to implement. So when I developed this idea, I had observed that of women who drink and smoke, about 90 to 92% of them quit as soon as they find out they're pregnant. And they do not drink or smoke or use drugs for the rest of the pregnancy. So they've already quit. We've got the hard work done. But what happens is that after the baby is born, they resume use, smoking, alcohol use, drugs, especially marijuana. So this program, Don't Quit the Quit, is designed to help maintain this quit that they established during pregnancy. A diagnosis of fetal alcohol spectrum disorder tells us that we need to, no matter what it takes, figure out how to build a relationship with this mother. It turns out, after having done this for 40 years, having taught hundreds of medical students, addiction counselors, nurses, any kind of clinician you can think of, that only a few people are able to do this. With training, we can substantially increase the number of people who have skills at this. And with quite a bit of training, we can help make many clinicians fair at this, but not good. So clinicians who think they were born with the ability to interact with this population of women are mistaken. It takes a lot of training, and even then, this is a very complicated task, and not that many people are going to be able to do it. We talked a little bit about some of the benefits of a diagnosis. One of the big ones is that children who have FASD on average have been exposed to 5 adverse childhood experiences. There's a saying, if you're familiar with these adverse childhood experiences, being abused, verbally abused, sexually abused, parents who are separated, parents who have substance use problems, parents who are in jail, on and on. That 4 ACEs does not make a winning hand for adverse childhood experiences. Children with FASD on average in North Dakota have 5. The way adverse childhood experiences originally was discovered was that people were looking at causes for adult health problems, depression, cancer, diabetes, sleep problems, on and on and on it went. And much to their amazement, they discovered that risk is increased among children who are exposed to these adverse childhood experiences. So the original thinking was that you have children who are exposed, let's just pick some common ones, to divorce and substance use and maybe some verbal abuse. That those problems linger for a while and then essentially go underground and show up later in life, increasing your risk for depression or anxiety or cancer or all kinds of later problems. That was true for a long time. We've clearly demonstrated that in North Dakota, that's not how this works. These ACEs don't go underground. They persist. Now, we're currently in the midst of a long-term study trying to figure out how best to manage these adverse childhood experiences. Seems like it's going to have to be different in children with FASD than it is in children who don't have FASD. Children who have FASD are likely to develop what are called secondary disabilities. Mental health problems, school failure, being victimized, being exploited, and early identification can substantially reduce the risk of these secondary disabilities. Early identification seems to be strongly associated with reducing the cost of care. And because the cost of care is so dramatically high for this population, I'm hopeful that even for people who have long ignored the importance of diagnosis and identification, that the cost burden will force them into beginning to do something about this. Early identification allows us to begin diagnosis-informed care. We don't treat people with FASD the same as people who don't have it. A lot of people think that's true. That's that we treat kids with FASD the same as other kids, but we don't. And a diagnosis allows us to establish a long-term plan, which is very crucial, especially for negotiating the transition from childhood into adult life. And there's a 6-8 year period there where a huge number of preventable problems arise because we have not identified these kids as having FASD and the need for changes in our planning. In summary, what do we want to do? We want to get an early diagnosis. We want to educate the caretakers about FASD, the course of FASD, so that they can utilize some anticipatory planning. For children with a mild FASD, we want to see them once a year to follow up, keep everybody up to date on what's happening, anticipate problems, and try to use some risk reduction strategies to reduce these. We especially want people to understand the dramatic impact of environmental changes. Multiple foster home placements is extremely detrimental in FASD. And because so many of them are unidentified and have such severe problems, they enter into a foster home, they don't do well there, they're moved to another foster home, they don't do well there. And as this process goes on, only after quite a while going through these things does somebody say, wow, I wonder if this could be FASD, and get them identified early. Foster care exists almost exclusively because of substance use. Every child going into foster care needs screened for FASD. One of the things that happens in FASD is we have to recognize that for many of these problems, these are not just behavioral abnormalities. These are impairments in the way the brain works. So for those of you that wear glasses, just take off your glasses and set them down on the table and imagine how you would function if somebody says, I'm going to use a behavioral program and force you to see better. I'm going to consequence you until your vision improves. Well, it's clear to us that we cannot do that, so we don't do it. People who have brain damage and impairments resulting from that brain damage do not respond to behavioral intervention that forces them to use those systems which are impaired like normal children do. So we can't force them to remember better or to pay attention more or to work faster or to overcome their fine motor skill impairments and write better. We can't force them to be able to recall stuff that they knew yesterday when they can't remember it today. We can't force them to use good judgment that they don't have. So I think recognizing that FASD produces impairments is fundamental to changing how we're going to do our interventions. These children are difficult to parent. Sleep disorders often persist. So many of these people have difficulty with sleep. Sleep a couple hours a night, wake up during the night, wander around the house, take all the food out of the refrigerator, eat huge amounts of food, get sick, hide food in their room. They have toilet training problems, lots of temper tantrums. They require lots of developmental interventions. School problems are very likely. Homework problems are something that require a lot of attention and should be thought through very carefully. What people don't understand is that the normal course of FASD is one of increasing severity. And until we get these kids, until we get these people diagnosed and we get the right kind of interventions in place, this is going to continue. So we have lots of excess disability in this population because we don't get them diagnosed early and we don't have the right kinds of intervention. This is a pretty relevant issue for parents whose children are in foster care and where the children are in foster care due to substance use. It needs to be configured into thinking and planning that these children are more difficult to parent than children who don't have FASD. The parenting burden is greater. So the amount of support parents are going to need in order to get their kids back from foster care and in order to have them do well is going to have to be increased a lot. And while we're making some modest strides in this, the changes we have made in the past 5 or 10 years were almost completely wiped out by the pandemic, where the number of terminations of parental rights has just exploded because of issues around the pandemic and overwhelmed child protection and foster care services. One of the parents sent me this picture, this painting that she did of parenting and FASD. So I don't know if you can improve on that as a portrayal of what a task this is for some parents. Not all, but some. Diagnosis at any age turns out to be a great thing. 81-year-old woman who figured out on her own that she had FASD. She made a great sacrifice to come see us. She felt that this really changed her life. But she had just almost inescapable sadness because of the impact alcohol use and fetal alcohol spectrum disorder had in her family. People of all ages are demanding help. I don't know how many of you have had letters from children, but we get several a year. We're going to do 3 more of these webinars. They'll be perhaps a little less general, more concentrated in certain areas. I'm anticipating this is going to be a prelude to some substantial advances. For those of you that follow this kind of thing, we've had funding from the North Dakota Department of Health for quite some time to do prevention. We are trying to implement prevention in prenatal care settings and among women who's had a child with FASD. So we have seen an increase in referrals from prenatal care settings. It's still very low. But at least there is more screening taking place. So our hope is that people are doing some interventions. One of the things that is needed is that in North Dakota, ultimately, we're going to have a substance abuse team at every delivery hospital. Our current system's just not working. There's no evidence that for opioids, amphetamines, other drugs like that, we're having much of an impact in our current system. So, and I'm only speaking now of women who are pregnant and affected children. We're going to have a substance abuse team in each hospital. I don't think we're going to have to hire new people. I think we can just help improve the expertise of people who are there. But without that, this is just going to continue. And just to reiterate again, across the world, rates of alcohol use are increasing. The number of people who drink is increasing. The amount they drink is increasing. The number of women who drink is increasing much faster than the number of men, much faster. The number of women of childbearing age who drink is increasing, and the number of women who drink during pregnancy is increasing. So the future seems clear to me. We're going to continue to ignore this and pretend it's somebody else's problem at pretty dramatic peril to the women of our state and our children. So I am hoping that this will serve as a catalyst for a renewed interest and a renewed lease on us doing something about this. We've spent 40 years studying what to do, developing the tools and techniques to do it. Now we just need to get it done. So I'm going to conclude there. And if people have questions, go ahead and ask them. I'd be happy to try to answer them.
My name is Missy Barranco, and I just thought I'd jump in. There was a couple of questions in the chat, so I didn't know if you'd seen those, but
Haven't.
One, so there was one, and then I kind of added to that, but I was curious because you talked, especially just now, about an 80-year-old woman who came in and received the diagnosis. And so part of my question was just about the importance of the diagnosis. Is it important? And then also, when a lot of times we're in my program working with birth moms. And so if there's any certain suggestion that you have on having the reasons for them to look into that diagnosis for their child.
I think the reasons are clear. One is it's presumably going to dramatically affect the care of their child. Two, if you're in substance abuse treatment, it's the perfect time to address a problem like this. If you can't address consequences of substance use when you're in treatment, it seems extremely unlikely we're going to be successful addressing that outside of treatment. So it's the perfect time to bring this up, get this dealt with during treatment. Postponing this is a disastrous idea.
So what about parents that are not in treatment? So maybe they have not even necessarily shared that they used alcohol or substances during their pregnancy, but you're just seeing a lot of behavior. So more thinking of that population that maybe hasn't even thought about this in that way, or
Well, as I think everybody has been thinking about it, and it's become the prevalent reason for not doing anything. It's too much trauma, it's labeling, it's stigma, on and on. The rationale goes for not bringing this up. The trick here is going to be when every woman expects to be asked about substance use during pregnancy. And if they're not, they consider themselves to be getting poor quality care. Every woman. If you're the mayor's wife, if you're homeless, if you're wealthy, if you're young, if you're old, if you're poor, every woman should expect to be asked in a research-informed manner about substance use. Every woman should be asked, should expect that the doctor caring for their baby during well child visits is going to be concerned enough about the well-being of that mom and that baby to ask about substance use. Now, it is tough bringing this up for people, but if we don't do it, we're just kicking the can down the road, and that has had disastrous implications for us. So we've just got to suck it up and learn how to do it and start getting it done so we can provide these women some help and prevent this recurrence of affected children within these families, which is maybe as much as 20 to 40% of all FASD cases. It's the place to do prevention. It's the place to improve outcomes. It's the place to save us money, and it's the place to improve our service delivery systems. So, great question. I might just have one more comment on that. So some women will come to see me and say, I was shocked when my doctor brought up that my child's problems might be due to drinking during pregnancy. That is worth thinking about, right? That's worth thinking about. How is it possible a woman can get through pregnancy and not have been told more than once by providers? Alcohol is very harmful for your baby in extremely low doses. Not too long ago, we had this foolish thing going on about a drink a day might be safe, a drink a day might help you relax, a drink a day might promote breastfeeding. People provided that stuff based on some good ideas, not data. The data in no way supports that idea. A drink a day is a bad idea. That's a lot of drinks during pregnancy. Far more than you need to put yourself at a level for risky drinking. The good news about this is we got lots of people who know how to do this. We just simply need to get them doing it in many settings, in substance abuse treatment, in foster care, all children going into residential care need to be screened. Children who are showing up at mental health clinics, special education, on and on. We have lots of places we need to begin to screen, just like we do for vision problems, hearing problems. Now, more recently, a lot of screening goes on for autism. So this is the future of FASD.
Larry, I have a quick question for you.
Yes.
So my name's Vanessa Rovig. I work at the North Dakota Center for Persons with Disabilities, and I'm on a project called Project Find Safe, where we work with law enforcement to help track individuals who may have a tendency to wander, whether they have a developmental disability or Alzheimer's or dementia, which is kind of why I'm on this call, because fetal alcohol syndrome, there definitely could be individuals who may be more prone to wandering. So obviously I'm not here to talk about prevention, but in your experiences, have you found that individuals who have fetal alcohol syndrome, do you find that those individuals have a tendency to wander? And if so, do you have resources or groups that you could potentially connect me with so that I can share this with families to let them know about this technology to keep their loved ones safe?
Well, this is a very common problem. Kids waking up in the middle of the night, wandering around the house. Little kids getting outside. Little kids being brought home by the neighbor. Kids being placed in foster care because the police find them outside. So we have many people taking care of kids with FASD who have alarms on the doors and all the windows. They have alarms on their kid's bedroom door. They have locks on the refrigerator. Very common. And we don't have a well-established protocol for management of this, nor do we have good technology for helping families. So rather than you seeking help from me, I think it would be much better if we sought help from you on how to just to develop a standard protocol where parents could access this with your assistance, because it's a big problem. The older kids leave impulsively. They get mad and they take off. So it's a little bit different situation with them. They're doing it impulsively, but lots of small children with FASD wandering, getting outside is a big problem. So I hope you'll contact me. Maybe we can do something together. It would be very helpful for us.
Absolutely. I can leave my contact information in the chat and we can get that set up.
Anybody else that has questions, thoughts, opinions? We have, I don't know if Carl's on the call. We have a national organization on fetal alcohol syndrome affiliate in North Dakota. Carl, are you on? So we do have the beginnings of a parents support group. The problem is that there are lots of issues with running a support group, and Carl needs some assistance here. So in the not too distant future, you'll get information about a conference we're going to have on FASD, likely a series of conferences over the next 2 or 3 years, because it's seems clear to me that not doing this on a regular basis is creating difficulty for us. So I anticipate that we'll have a regular FASD conference in North Dakota, maybe for the surrounding area as well, most likely, because places like South Dakota, Montana are absolutely desperate for help with FASD. At our center, we see people from North Dakota, South Dakota, Montana, sometimes Iowa, and before the border closed, people would come down from Canada. So I think that just gives you an idea of how desperate people are for help with this and how difficult it is to get help. Anybody else that would have a question?
If we needed to have a screening done, what would be the process?
So this year we have now published 3 papers validating a screening tool we've been using for a long time. We've had the data for a long time, but haven't had it quite in shape to publish it. So we've now published data on a screening tool for people 3 years of age and older, are expanding that down to, I don't know if it's going to be a birth to 3 screen, but it's going to be a younger screen. And you can call up, it's a simple checklist, not complicated to do. The only thing that's complicated is that you give it to the parent, foster parent, social worker, somebody, and then another person who also knows the child has to supply some information. So you get, it's a dual source checklist, but I'd be happy to send it to you if you'd like.
Yes, please. I'll put my contact information in the chat. Thank you.
It's 10 minutes after 1 on a beautiful summer day in North Dakota. So I appreciate you all joining us. We'll be sending out some information. I think at the next one, we will list the 3 topics and the 3 dates all at the same time so people can plan ahead. Thank you all so much for joining. See you.
Thanks, Dr. Berg.